Now with us today in this webinar are three panelists who are experts in their respective fields. Dr. Halina will share with us her expertise in clinical reasoning, Dr. Ismail in simulation, and Dr. Tong in clinical supervision. Without further ado, let me introduce our first panelist to you. Professor Dr. Halina Halizah Siraj truly doesn't need any introduction. She's a well-known figure, a motivational speaker, who is also a professor of obstetrics and gynecology and medical education in UKM. Currently, she is director of the Center for Liberal Studies, or CITRA UKM. And she graduated with Masters of Clinical Education in 2018 from the University of Melbourne. And during that time, she did extensive research in the field of clinical reasoning. So without further ado, it gives me a great pleasure to call upon Dr. Halina to share with us the experience on clinical reasoning. Halina, the floor is yours.
Okay, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all. It is really an honor to be presented here in this webinar, and thanks Progza for the introduction. And let me share my screen. I would not most probably say that I'm an expert in the area of clinical reasoning. However, this has always been my interest. So my topic will be teaching and assessing clinical reasoning, enhancement through e-learning. So just to be a bit nostalgic and going down the memory lane, I'm sure everybody knows Sir William Osler, the father of modern medicine, modern clinical medicine. And when he was younger, teaching in McGill's, Montreal, he used to teach students in an amphitheater, where, as you can see, it is a very, I would say, I don't see any women there, but definitely this is the day where it's only men who learn medicine. But when he was in John Hopkins, he started to bring the student out and went to the clinic and the wards, and starting this, what we know as our routines in clinical teaching, inspection, and then of course palpation, auscultation, and contemplation. So he actually said finally that medicine is learned by the bedside and not in the classroom. Okay, so basically this has been the forefront, or more or less the gold standard of clinical teaching. That is still having your student to be immersed in the clinical setup, the direct interaction with real patient. And I would like to start from the very beginning of this presentation, that whatever we are discussing today, i.e. e-learning, is not going to replace this. And that's why we are talking in terms of enhancing the student experience. It is mainly about the student. And we have the technology now. So basically, this is just to highlight to you a very recent paper for those who wants to see how can we enhance our student experience when we are actually having that benefits of having the patient as the passive teacher between you and your learner. And this is an AME guide, the Association of Medical Education of Europe. And this is mainly on supporting the student. And I really encourage you to read this paper. It is an open access in medical teacher. So in our discussion this morning, I will just go into, at a glance, what clinical reasoning is all about. And of course, we have to more or less look into e-learning. And I will just touch a little bit on this artificial intelligence and clinical reasoning. Are we still going to be relevant when most probably the AI is going to do a better job, reasoning out our patients instead of us with all our shortcomings and inadequacy? Yeah? And we look into some papers that shows the effectiveness of e-learning in health sciences education. I know that among the audience, you are not just medical educators, you have nursing educators, dental, and other allied healthcare educators. And of course, later on, to see how can we enhance our teaching and assessing clinical reasoning using e-learning methods. Well, this is interesting. This is basically clinical reasoning is about how doctors think, how healthcare providers think. And that has been a mystery for a very long time. And if you do not want to read all those, academic papers, maybe, it's nice to grab this book, How Doctors Think by Jerome Groopman, a US bestseller, a Harvard clinical, he's a neurosurgeon, if I'm mistaken. And this was written most probably in 2008 or 2010. But a few years later, an Australian wrote another book with the same more or less title. And I've read these two books. It's very interesting. It is actually telling you in a very narrative way, actually how doctors think. And this book is intended for the patient, to read, more or less, so that the patient can actually help the doctor to come up to a better reasoning with the information that the patients are going to provide. So I would recommend this book if you have any interest to know more about clinical reasoning. But basically, clinical reasoning is definitely the most important ingredient in our professional self-image. That's the reason why your patient come to see you every time, because of your clinical reasoning ability. And this encompasses all, as I said, medical, dental, nursing, and other allied healthcare professionals. And there's a lot of definition of clinical reasoning, but I just would like to come to this. First, it is actually a process where we integrate and apply different types of knowledge. Anatomy, physiology, biochemistry, pharmacology, all, sociology, everything that we need to integrate and apply. And of course, we are facing patients' data that's being collected through our physical history taking, physical examination, and the relevant investigation. And we need to think critically about it. Now we need to weigh and analyze all those data and evidences. And definitely we need to reflect and contemplate on the process of coming up to a decision, which is diagnosis, treatment, and also prognostication of our patient, and to develop and construct effective treatment plans. So basically this is what clinical reasoning is all about. And well, this is definitely the higher order thinking skill. And it's not just about remembering or understanding. So if your student ended up by trying to mimic your way of thinking without really, applying, analyzing, and creating their own diagnosis, I think we defeat the purpose of teaching clinical reasoning. They have to be doing this on their own, on the go, when we are no longer there. And this is actually a very tall order for all educators. Of course, we have heard about medical errors, in making diagnosis, in making decision, either the patient should be admitted or should be discharged, the kind of treatment, when to actually start the treatment, the medication, sometimes the dosage is incorrect. So we might even have inadequate supervision and faulty communication, and all these are reflective of poor clinical reasoning skill. So basically, this is just a very a glimpse of what is in the theoretical aspect of clinical reasoning. It is the interaction between the non-analytical or system one, heuristic, intuitive, the experience-based medicine, and the analytical system one, which is more systematic. And this is actually the evidence-based medicine. And a clinician would actually integrate all this every time he or she is having an encounter and interaction with the patient. So basically, this is a very important difference that we as educators has to know, because our students, the novices, they are coming in, with this explicit reasoning. They are mainly operating on system 2, which is the analytical reasoning strategy. They'll be holding the Oxford handbook, going around with the algorithm, this stager, and then it will click into two pathway, and then another flow chart. So this is basically slow, serial, deliberate, and effortful, very conscious and controlled. Unfortunately, our novices, because of their inexperience, will tend to recognize, all these features, for example, in the face. They will actually look at that parts by parts, the eyes, the ears, the nose, and the mouth, and they will, their mode is search to find and they're very focused. As compared to expert who are supposed to be having a lot of exposure, they are usually using system one, which is heuristic. And this is unconscious and automatic. And of course, this is also not without any disadvantage, because we tend to look at things as wholesome. And this is making us becoming very good at picking up, symptoms or signs that give a global impression. So this is the differences. And basically, when you are trying to teach your student clinical reasoning, this is bringing them along this journey of what we call as RHYME, clinical competency frame. They will start off as reporter. You know how irritating it is when a student just rattle out whatever the patient said, and this is mainly, their attempt in gathering information. They don't even know which one of that information is important. And of course, diagnostic accuracy is way down. So they will be just gathering data, just like a reporter, and then they will start to interpret that. That is actually the next step. And this is when they start to understand that certain disease has certain illness script, and they would start to recognize pattern, and then they will cross over when they become, competent enough to manage the patient, making a right diagnosis, a good one, and a list of differential diagnoses, and finally deciding what to do with all those data. So, and finally, I hope we are actually at the end of the E, which is educator or expert. So at this point of time, our data gathering becomes very targeted, and of course, we have a better diagnostic accuracy. I think this is a very important illustration of the journey of our student when they want to come from becoming just a reporter until they can manage a patient. This is actually just, going through what is the steps for clinical reasoning, particularly diagnostic reasoning. It starts with the patient story. That's why it's very important for our students to meet the patient. And of course, e-learning is not going to replace coming up with the conclusion that we don't have to have patient anymore. No, they have to have this interaction. They have to collect all the data, and they have to be good in their history taking, communication skill. They have to be very observant in their clinical acumen, and finally deciding what investigation that will give them more data. And with that, they will go to the next phase, and finally to the diagnosis. And of course, the student's knowledge, their context, the experience are all taken into account. So basically, this is another way of looking at it. They collect the data. So if your student have problem with history taking, physical examination, and deciding which investigation is important, they are to start off with, they are disadvantaged in the very beginning. So make sure that they are good at this, and then we need to train them and more or less facilitate this problem representation where they can frame it. And finally, assessing their own illness script. This is like a folder of, their theoretical knowledge about the diseases. If they are in surgery, what are the common surgical disorder that they need to know? If they are in internal medicine, if they are in ONG. So these are their more or less repository, and from there they will have this contrasting and comparing process until they find the match. So they find the diagnosis. This is a therapeutic reasoning steps, and I'm taking obstetric as an example. After they're having a diagnosis, more or less, they have to decide, is it an inpatient care or outpatient care? And let's say if it's in inpatient care, they need to assess, of course, in obstetric, the mother and the fetus. And of course, after that, after they have been given treatment, do you actually continue the inpatient care or can they be discharged? And so if they are needing inpatient care, what is the justification? And for step 4, it is the timing of delivery, mode of delivery, intrapartum care, and finally postnatal care. This is actually a therapeutic reasoning steps. So, well, with all that, we will most probably have to ask this question. Will robot replace human doctors one day? When all this artificial intelligence with the machine learning and the deep learning, might become, better in reasoning out what is wrong with the patient, providing they get all the data. So my take is this. Yeah, I don't think so. The robot is going to replace doctors, because even though yes, the artificial intelligence are able to be more efficient, less error prone, and most probably more seamless. but we still need the human doctor who can reason, clinically, intuitively, and this is the non-linear process which the robot cannot actually take over. And we can respond to uncertainty and emergency. Communication and empathy is definitely more automatic with us. And of course, we can provide personalized care. So don't worry, educators will still be in great demand. Yeah. So now let me go to e-learning. E-learning is basically it's just an educational method that facilitates learning. In no way that it can actually replace whatever the gold standard for instance in clinical teaching. And this is using the information technology that we have, and particularly to give opportunity to learners to have access. And it is rather than a very opportunistic, haphazard, non-standardized method of clinical teaching, we can now become fairer to our learners to have more opportunity for them. So the advantages of e-learning, definitely there's a lot. It is active learning, it is learner-centered. There's a lot of learning delivery. We have a lot of control in terms of the content and the location and the time. The multimedia menu is non-exhaustive. There's a lot of diverse learning style and objectives. And the good thing is that, particularly for assessment, is actually the automated tracking and reporting and learner self-assessment. Sorry for the spelling. But this is a very recent paper, I think somewhere in 2018. Not so recent, I mean to say, but they have actually looked into this barriers and solution to online learning. And basically, this is the key barriers from the paper. And I'm sure you agree with me. This is time constraining. Yeah, we have poor technical skill on our part. We have inadequate infrastructure. The internet is always very slow. There are absence of institutional strategies and support. Maybe not absent, but lacking of that. And the negative attitude of all involved. And the solution is definitely we need to improve our educator skill. We need to have incentive and reward. I think even though I cannot see you, I think everybody is nodding their head. So that for the time spent on developing all this content, and of course we need to have improved institutional strategy and support and positive attitude of all involved. So having said that, I think Proza, my purpose of presenting this morning is if we can actually more or less reduce the apprehension and the negative attitude and feelings towards e-learning, that would serve the purpose of this discussion. Now, so how do you do that? And how do we enhance clinical reasoning through e-learning? So this is the continuum of competency. My other two speakers are going to, provide their input in different parts of competency. But basically, this is the easiest way that we can actually have Kahoot, more or less, it's a gamification. It is a quiz where you can actually test your student. And not only that, we can actually see who are the students that need help. So I might not have the time to actually go through this, but would be in the question and answer process. But this is basically when you can have maybe 10 spot diagnosis on certain disease, and you can really see some students who are good at it and who needs help. And Kahoot will tell you, these are the 6 students that need help, because out of 10 questions, they only answer 3 right. And you can actually pinpoint to the student, providing you have their metric number. Now, another thing is actually this DXR clinician. So this is just one of the example. It is a web-based software that helps teach and evaluate clinical reasoning skill. So for Faculty of Medicine, we have actually purchased this, and they have this menu of patient, and you can just choose. You might not have to have all of their menu, but you can. The license can be given to you to have other input, and you can change the patient character and data. And of course, they try to simulate as best as possible, the process of going through the questions, and there will always be answer to all the questions. And if you don't ask enough questions, they will not allow you to go to the other stage. And of course, this definitely need a lot of readiness in terms of the teachers and also the learners. Yeah. And the good thing about the XR clinician is this: at the end of that, there is a scoring paradigm whereby the student is going to be scored according to their diagnostic performance. Let me just go through that. Of course, 100% is impressive, very good, acceptable. shotgun. They're just, and premature, lucky, and then anchored. So you know that in the very beginning, they are already anchoring their diagnosis, premature, and omission and inadequate. So this basically will tell you the e-learning, the technology is there to tell you which among your students who needs more assistance. And finally, there are so many. I would recommend this practicum script, and this is mainly for specialists and postgraduate. And their level of difficulty is actually graded. And also this one, Prof. Ismail is going to talk more about this concept. So finally, ladies and gentlemen, enhancing clinical reasoning through e-learning is basically trying to be more learner-centered. It is no longer you
the
as the fish on
e-learning,
the
the technology
stage.
is there,
And that can
tell you
actually
which among your students
bring
who
out a
needs
very
more
insecure feeling.
And finally,
as,
there are
as
so many.
educators.
I would
I
recommend
really
this
totally
practicum
understand.
script. And
But
this
you
is
know
mainly
what?
for
This is a
specialists
very
and
exciting time.
and
where we will
their
become
level
co-learners
of
with our students.
difficulty
It is
is
safe
actually
now to
graded.
say, I don't know.
And
Let's
their
look at it in
level
the
of
co-learners in the search engine, and it is all well and acceptable. So, ladies and gentlemen, I hope I have, just more or less giving some input into most probably persuading you to come over and, making clinical education belongs more to the student rather than to the educators. So with that, terima kasih. Thank you, Proza. Back to you.
Okay, thank you very much, Halina. That was very enlightening. And I'm sure there's a lot of questions in the minds of the participants, but we'll keep the questions to the end. We have two other panelists in line. The next panelist that I would like to introduce, Professor Dr. Ismail Muhammad Saibun. You can see his bio sketch on the screen there. He qualified as a doctor in surgery, orthopedics and traumatology, but subspecializes in emergency medicine. And he's the first person in Malaysia to receive the Certificate in Healthcare Simulation Education, or CHSE, from the Society for Simulation in Healthcare in USA, after going through a simulation preceptorship at the Weiser Institute, or the Winter Institute of Simulation Education and Research at the University of Pittsburgh. This was, I think, way back in 2011 or so. And he is also instrumental in setting up the International Training Center of the American Heart Association here in UKM. And he also initiated and developed postgraduate training in emergency medicine for doctors, and also a bachelor's degree for paramedics in Malaysia. So lots of credit to his name. His key research interests are, of course, in emergency medicine, pre-hospital care especially, and he's written a best-selling book on that. And also, he's passionate in healthcare education. Formerly, he was the head of the emergency department in UKM for 11 years. And he's also been deputy director of the hospital and deputy dean of the medical faculty. And in his leisure time, he likes to innovate, cycle, swim, and travel. So with such a colorful background, it gives me great pleasure to present to you Dr. Ismail, to share with us the next part of this webinar. Ismail, on to you.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi and salam sejahtera. Good morning to everyone. First of all, thank you very much to Prof. Zaliha for a very kind introduction. Blush pula saya. Okay, can I share my screen? Okay, thank you very much. And welcome everyone to this morning webinar. And first of all, I would like to thank you, Prof. Zaliha, and also Prof. Harlina, for inviting me to this webinar. And I was given the task to speak on simulation-based clinical teaching, learning, and assessment roles of digital online learning. I hope I will do some justice to this topic. Okay, first, some disclaimer and disclosure. I use a lot of photos, graphic, but none of that is only for presentation purposes. I do not promote any of those products. And I'm also the presently chairman of the Malaysian Society for Simulation in Healthcare. And I'm no expert. I'm just basically know a little bit, and I would like to share with all of you. Right. Okay, this is basically what I'm going to talk about this morning. On clinical teaching and a little bit on simulation-based healthcare education. For those of you who are not very sure or well versed what is simulation-based healthcare education, I'm going to enlighten you a little bit on that and some of the different modalities that we can use and how can healthcare simulation help in online clinical education. First of all, let's look into this clinical teaching. So it is a form of interpersonal communication between a teacher and a learner. And this teaching process is basically it's a transaction involving the teacher, learner, and basically the environment. All right, and the whole idea is basically to develop this dynamic interrelationship so that the learners will gain so much of knowledge, attitude, and psychomotor. So this is basically the three things. We have the teachers, whose role is basically to give the knowledge, the skills, and also to develop the attitude of the learners. The learners who goes there with certain knowledge, experience, and basically important thing also, both of them, their interactions have to have in a correct positive environment, which is the presence of patients, relatives, staff, and so on, the ward. However, I think nowadays, with the problem with the pandemic, this thing actually being taken out. The environment is basically taking out, is being replaced with some sorts of a virtual environment. So how can we get this interaction still going on and to have an effective clinical teaching? Well, this is some of the founders of clinical teaching. Some of it would be just a repetition of what Prof. Halina has mentioned, but I think I need to mention. I think these three person, Ibn Sina, William Osler, and Abraham Flexner, are basically the fathers of modern medicine. Ibn Sina with his book of the Law of Medicine, and then William Osler is famous for bringing the student to the bedside or bedside teaching, which we've been using until now. And it's like the gold standards. If you don't get the student to the bedside, that's not considered as clinical teaching. And last but not least is this guy, Abraham Flexner. Maybe not many people talk about this guy, but this is the person who basically tried to introduce clinical reasoning in the beginning. It was about 100 years ago, where he said that education in medicine involves both learning and learning how. And for the student to know, they need to know and also to know how things happen. So this is basically what's the basis of we have clinical reasoning nowadays. And healthcare education has been delivered through many methods. All right, we have lectures, a small group discussion, problem-based learning, which basically we use all of those things. Okay, for the sums of the skills, we have a hands-on training on the skills lab. We also be promoting to have seminars for students to present. Bedside teaching is the gold star or the gold standard of this thing. Okay, we also start to teach student reflection, and also we have bring a little bit of simulations into undergraduate student education, and now with this web-based thing. So what is simulation-based healthcare education? Before I go into that, I think I want to clear some misconceptions about simulation, because I think a lot of people have different ideas of what is simulation is, and based on what we know, I think a lot of people think that if you don't have the simulators, you are not doing simulations. So examples, if you are doing with this for Hamlet maneuver, you have to play with the simulators, you have to play with some this electronic patient called SimBand, or you have to play with this arm, so it's a dummy or mannequin or something that you have to poke into for the chest tube. So you need to have all the simulators. But let me tell you that simulation is not just that. Simulators has though been basically given the main thing of, or the main crux of simulation. But simulation in education per se is not about the simulators. It is about a technique how you imitate the real thing. All right. A definition from the Dictionary of Healthcare Simulations define simulation as a technique that creates a situations that is basically allows the person to experience a real life event. All right. So therefore, simulation is the technique and not the technology. When I say technology, basically we're referring to the simulators. And recently I was called to give to conduct a workshop in one of the IPTA, and to my surprise also they were asking me, where is all your high-end fidelity simulators? We came here to see the simulators, but we only see you and your team talking us how to teach. So that is actually one big misconception about simulators, because if you want to talk about simulators, then the best person to talk about will be Lidls, or will be Indisium, or Mati, or whatsoever company that have doing this thing. So in terms of clinical teaching, what we say that clinical teaching basically must involve real patients. Okay, something like this: we have a real patient, and student will be crowding around. You're going to teach them. That's mainly about real patients, or you're going to discuss about real patients. If you don't use real patients, okay, if you use a dummy or something like that, and even in the case history, it is called simulation. So anything that is not using real patient is simulation-based clinical teaching. All right, and to tell you the truth, I think everybody has been using this simulation-based clinical teaching, maybe without knowing what is it. All right, so simulation is not rare. It's not something which is new, and I think all of us have used some sorts of simulation-based clinical teaching. The only thing maybe we're not sure that is thing called simulation-based, but anything that's not dealing with real patient is simulation. So you can either, you are doing like this, like example, you want to teach someone how to do an IM injection, you can even use like an orange with a syringe to let them feel the gift, or you can use a simulator. You can just poke into the lung, or sometimes you don't have to use a simulator, just going around and talking about things, and that also is called simulation, because as long as not real thing, they're not real patient. And there are different modalities of healthcare simulations. Generally, Dr. David Gover has divided this into 6 different things. The first thing is role play. Role play is a form of simulation. Sometimes you just can talk about. You say, oh, just act on. You are so and so. You are the doctor. You are the nurse, and he's acting as a patient. You just talk about it. How you're going to go about. That is actually simulation. Now, if you have someone who come in and act about the whole thing, then you call it standardized patient, or you have the actors where you have the performance and also the role play. Then, if you want to do some small, simple procedures, and you don't want to have a human being or a patient or an SP, you do it on a task trainers. And then after that, screen-based simulation or computer-based simulation is another modality, and now it is coming up, and basically a lot of people are talking about it. And during this pandemic, screen-based simulations or computer-based simulations actually come in very handy. Next is actually electronic patients. Examples, this is where a mannequin with a lot of electrical system inside, it can breathe for you, it can talk to you, it can have pulse. You can do certain procedures on this thing. You can even cough and bite your fingers. Last but not least is the virtual simulation. This is also another modalities of simulation, but you use VR or even AR, virtual reality or artificial augmented reality. Sorry. So these are some examples. Role play. Okay, SPs. You can have SPs or even actors that this thing. Part-task trainers. Part-task trainers is something that when you do, for you to practice certain, you have a task, only one part of the task where you can, and you need to use a simulator for that. A screen-based, you can have lots of screen-based simulators right now. Even you can have a program and the one that is non-program screen-based simulations, electronic patients, something like this, and also a virtual reality. So these are the 6 modalities of simulation. And when we talk about healthcare simulation, we are referring to any one of this. So in teaching simulation, there are steps on how to do it. It is not that, okay, you have a simulator, go and play with it, and then after that, that's it. It has steps, it has things that you need to do. Then only you call simulation education, right? And the step goes into a lot of things to be done in preparations. Okay, when you say preparation, about the scenario, about the script, about the learning objective, and so on. And all simulation, you should start with a briefing. Even when you're doing a screen-based simulation, it has to do with the briefing on how to maneuver those things. And then after that, you let the students play with the simulation activity. Right after the simulation activity, we have this thing called debriefing, which is one of the most important thing in simulation. If a simulation, just having the simulation activity without debriefing, and you are not basically doing simulation, you're just playing with a toy. And then after that, you have reflections. The student have to reflect and evaluation. So what is debriefing? Actually, it's a process of understanding what the learners are thinking. We, as the educator, have to understand what they are thinking. So they have to talk to us. And basically, what we as educators trying to do is try to make sense to them of what did they have experienced or gone through. That is the most important thing. If not, again, it's just going to be a child or a person playing with a toy. There are many ways how you can diffuse, how you can debrief these things. These are one of the technique we can do. We can do debriefing. Is basically we're going to diffuse the emotion and diffuse any wrong conception. We're going to delineate what's the learning objective, and in the discussion we try to bring back the experience, and we're going to review the action during what they do, what they have done. Then we have the in-depth discussions of the issues or the things or methods pertaining to it. But finally, how they're going to use this new knowledge in the future. So that is important in debriefing, and all simulations should go with that. And again, I think I reiterate what Prof. Hasana has mentioned. Face-to-face is still the best method of clinical teaching. All right, whether face-to-face in real physical or face-to-face with a synchronous e-learning is still the best method. Um, and the role of simulation is not to replace a face-to-face physical teaching. No, it's not. It's never meant for that. What is the role of simulation all this while is to bridge the gap that is left by the current methods of teaching. Examples. There are certain things, example, if you want to teach about a certain disease and how you should treat them, and the case never comes. So this is where simulation comes in and bridge the gap. And we can basically create a scenario of the case that we want to show to the student or we want to teach them. So this is one important thing. So it's meant to bridge the gap. And in the current situation, we are basically see how simulation can best assist in order to bridge the gap. And the gap is basically having a face-to-face contact physically. So this is what I think. Basically, simulation can help in terms of the online clinical teaching through this. We have all these modalities, but I think for the online, these are the important things. One, I think the role play has a big role in terms of clinical education. In terms of you can teach history taking, you can do counseling or breaking bad news. This is actually one of the things in terms of role play. Screen-based simulations with computers, we can do critical appraisal, clinical reasoning, data interpretation, and basically also on which basically comes up to decision making. On top of that, screen-based also can be used for basically just to impart knowledge. ASPs, standardized patient or actors, can be used in physical examination. Well, I will share after this. And virtual simulations, especially with haptic response, come in very handy. But there's a question mark there is actually, I'm going to explain why, because we are not there yet. And if the student are allowed to use a sim lab, I think the other thing can be used. Okay, this is actually how I see the undergraduate clinical teaching can be done or can be assisted by simulations. We have these three things. We have what do you call this cognitive training. We divide it into cognitive training, affective training, and psychomotor training. And for cognitive training, generally we look into knowledge, so giving knowledge, which we can basically do on online lecture or basically whether it's synchronous or asynchronous or screen based. And the second thing actually to teach them about clinical reasoning. Okay, for effective teaching, we want to know to give them to teach them on soft skills. Again, this can be done through this screen based or even role play. For psychomotor training, Okay, we need I divide it into two. One is how to teach them to do examination. When I say examination, referring to physical examination, examination of the lung, the heart, the abdomen, the trachea. I mean the neck, and also the CNS or musculoskeletal, and also the procedural. For examination, generally in terms of I divide it into two. One is execution, basically how they execute it, how they do it, and the other thing is elicitation. Execution, I think, is doable. We can do it with just an online method. But in terms of elicitation, I put it in red. I think this is a little bit of a challenge how to do this in this type of environment. Then again, also with procedural, about the execution, I think should not be an issue. But in terms of elicitation, there will be a little bit of an issue. Uh, the top one is on teaching and learning. The bottom one is on assessment. How can we do that? So I think the black mark is not difficult, but the one in red, I think, is the challenge. Now let's see the teaching and learning on cognitive. Now, these are some of the things we can use: screen-based simulation with a role play simulation plus with a VR. These are all the modalities of simulation that we can use here. In terms of knowledge, I think that's not much of an issue. You can do an asynchronous. You can videotape whatever you want to tell the student. You can put it into Screencast-O-Matic or any of this webcaster or the Screencaster, Camtasia, TED-Ed or something, and basically open the discussion platform. You can use even Facebook can be used as a discussion platform or partner whatsoever. So this is asynchronous teaching of knowledge. But for synchronous teaching of knowledge, again, we can use what we are using now: Zoom, WebEx, Microsoft Teams, or Google Meet, or whatsoever. Again, teaching of knowledge, I think, is not an issue. But how about teaching of clinical reasoning? Teaching of clinical reasoning, we can do again synchronous or asynchronous. Asynchronous, we can use a TED-Ed, which is an app where you can do on your own. If you have time, you just type that and you can explore, where basically you put on certain videos or certain script, and then there will be a pause where you can put all the questions. And if the student cannot answer the right question, they will not go to the next step. So it's something like I think it's a good app that you can use. We can also use DXR Clinician. I think Prof. Halina has mentioned a lot on DXR Clinicians. It's a program that UKM has purchased, and I think everybody please come and learn about how to use DXR Clinician. It can be very helpful. Or even we can, in the emergency, we use hard code. There's a lot of this asynchronous thing that you can do, where at the end of the day, they can give marks and how the student perform. Or we can use a synchronous way of clinical reasoning with all this Zoom, WebEx, or whatsoever, and basically we can use also some YouTube, in terms of the sounds, in terms of the thing that you have to interpret, and basically we can use a feedback app like Kahoot, Mentimeter, Poll-Daddy, and so on. So when you do the synchronous thing, you can online, you can put a question, the student can basically answer online from their home, and you can see who's the good student and who's the weak student that cannot understand. So these are some of the things that we can use, which is part of screen-based simulation. In terms of cognitive assessment, okay, just now I was teaching is assessment. We can use a screen-based simulation or role play. Again, we can do asynchronous in terms of the DXR Clinician. This is where if you use the DXR Clinician program, they can basically score the patient and score the student. And I think Prof. Adnan has showed you just now who did excellently and who did actually quite poor. Or if you want to do an asynchronous thing, we can do one of this in terms of assessing knowledge. We can do in terms of open book time limited. I call it OPTL assessment, where we give question and then we limited the time, and basically we can put questions more towards data interpretation or decision making, so that even though it's open, there will be no pages that they can go through and basically just fish out the answer from there. And we have to minimize recall questions. So this is one if you want to do assessment in terms of cognitive with asynchronous technique. The other thing that we can do in terms of synchronous technique, you can use Zoom, WebEx, again, all this thing, and with some data interpretation. So you can show them an ECG or show them an X-ray, and they will basically able to do the interpretation. Now, in terms of cognitive effective, okay, in terms of, I take example of like history taking and data interpretation. We can do asynchronous with the DXR Clinician. So guys, I think this is an opportunity. Go and basically get used to this thing, or you can build your own using a TED app, online app. All right. But I still feel in terms of effective, in terms of their how their attitude is, a synchronous way of assessments is still to me the best. Now let's look on this one. This is the challenging part. How do we teach psychomotor, and how do we assess psychomotor? Um, in terms of psychomotor, again, I divided into two: one examination skills, and the other one is procedural skills. In terms of examination skills, we can use a screen-based, a role play, plus either synchronous or asynchronous. So in terms of execution, in terms of to see whether we can teach the student how to do a certain examination, I think that's quite easy. We have the video. We show the performance of the examination technique, and basically we can basically discuss with them, so then for them to understand and how to do it. And basically we can ask the student to perform this thing at home with their family members or with their friend. The only thing is that their friend will have normal findings. Now, however, I think to enhance this thing, this is another technique that I would like to propose, is actually we do what we call as a video demonstration of the examinations with some correct and some incorrect steps or the technique. And we can show them, we can have like 3 or 4 or even 10 videos. And when the students see the videos, can they pick up which one is the wrong thing? So that is not only them to memorize, but they're able to know which is the correct technique for them to perform. And basically that will basically come up with a debriefing at the end of those things. So that will basically enhance the student from just doing to memorize. They would know the understanding why they have to do a certain examination, and what they're supposed to do. Next, okay. This is actually some of the simple things, games. Okay, students like to play games. These are some of the medical games that is available online. You can have doctors basically attending to a patient. They have even like surgery. So you can play with this game, and a student can go through with this thing. This is free, but where the explanation again is free for you all because you can have bought. But this is actually really free that you can go, and basically it can teach you the steps of doing certain things. Now, what about the psychomotor in terms of the elicitation? Now, when we do elicitations, William Osler was saying that's this IPPA, inspection, palpation, percussion, auscultation. I put the P in red because I think for inspection is no issue. You can show a video, you can show a photo, student can learn. For the hearing, for the auscultation and the percussion, we can give them hearing cues, which add to that the sounds. We can get the heart sound, the lung sound, the percussion sounds that basically you can easily downloadable from the YouTube, from the internet. But for palpation, this is actually the challenge. How do we give students to palpate something? Because the computer, you can only palpate the hard cut casing of the computer. Now, there are certain things which is still in progress of making thing. We have the VR with haptic response that if it's available, it will help us in terms of some examination. Example, doing abdominal palpations, doing a VE and so on. It have that haptic response to give them the feedback of responsive. You can also do a 3D printed mannequin, something like this. So you can basically ask the students to examine the mannequin, but they have to purchase a mannequin, so it's a bit expensive. Or we can do something like our project called the Hitman 2. Next, these are some of the 3D printed stimulator, which is already available, and they can print the whole person actually if you want to. For psychomotor, in terms of procedural, I think the execution is the same as the physical examination. It can be done, you follow the step. But for the elicitation, again, this is actually something that how do they perform, and you can elicit whether they do the procedures correctly. Again, you need a lot of maybe 3D printed mannequin. You can do with that. You can use VR, haptic, example, some robotic surgery, which I know medical students don't do that, or some VR ultrasound. And maybe ultrasound is one of the way of the future that I think it can help us in terms of clinical teaching. So the last part of my talk is actually, can the SIMLab be used? I think this is a question. Can it? I don't know, but to me, I think it can, provided we take certain safety precautionary measures. We've done that now. We in the emergency department have done, again, a face-to-face teaching to our staff in terms during this pandemic. And so far, alhamdulillah, none of them are down with any problems. But I think it has to be thing. We have developed a strict checklist, like an SOP, in terms we limit the number of participants, the room size have to be very adequate. We need to do a COVID-19 screening history, and also really look out for the signs that's present. If they have any of these things, they should not attend. We must ensure hand sanitization all the time. And basically, students need to wear PPE. But I think one of the important things is number 7. The people who runs the simulation lab or the skill lab have to clean all the equipment before and after each group come there and practice. Not the session, but each group to come there. So everybody who goes there, they have to clean the thing up, and when they left, they have to clean it up before the next team comes in and learn. So finally, it's on something to think about on this called open online medical education. Can it be done? I think yes. This is a good time to ponder on this idea of a medical school that provide the curriculum and will do the testing, a simulation center that allows the student to learn hands-on, and the hospital to become the buddy of the medical student. But this is something to just to ponder. With that, thank you very much, and I pass back to Prof. Zaliha.
Thank you very much, Ismail, for a stimulating talk on simulation. We shall take all the questions. The questions have started to come in, but as I've said just now, I think it's probably best to take the questions at the end, because the 3 topics are actually quite interrelated. We will move on to our next speaker. Okay. Our third speaker, last but not least, is, I think he's the youngest of us all. But nonetheless, definitely not the least experienced. There's a vast experience in many fields. He's a family medicine specialist with a PhD from Sydney University. Currently, he is the Assistant Dean of Teaching and Chitra at our faculty. And he has also been heading the unit of interprofessional learning for the faculty for quite a number of years. He is the president of the Qualitative Research Association of Malaysia. And formerly, he was also the past president for the Malaysian Primary Care Research Group, as well as the Academy of Family Physicians of Malaysia. And his previous administrative post was as head of department for our family medicine department. And without further ado, I would like to call upon Dr. Tong Seng Fa to deliver the next sharing session.
Thank you, Prof. Zaliha. It's my privilege to come and present my experience of clinical supervision. And now it's become more challenging because we have to move on to online and see how can that be done possibly. And I'm sharing my screen now. Okay, hopefully the screen is on now. And and thank you Pengajaran UKM to co-host this webinar on online clinical teaching and learning. And when we talk about online clinical supervision, before that, I think we need to clarify what clinical supervision. That's the cartoon picture of a clinical supervision. Basically, it creates some form of anxiety sometimes, but to the student or the supervisee, it is a kind of on-job training. So perhaps in next 5-10 minutes or so, I'll probably talk a little bit more about clinical supervision before you move on to the online, because we need to speak at the same definition. And when we move on to online clinical supervision, the second half of my sharing session, we will look at how online has altered some of the clinical supervision. Okay, this is important to notice. And perhaps I will be talking a lot about conceptual rather than technical, because the technical bit, I think Prof. Ismail and Prof. Halina has shared quite a variety of techniques and technology we can use, right? So what is clinical supervision? Clinical supervision really is about producing an outcome. You can see here, it's producing an outcome. But here, what outcome are we expecting? Obviously, it is a profession. It's a competent professionals that can practice. It can be doctors, nurses, paramedics in healthcare and healthcare team. But I think more than that, I think something about self-assessment skills is also important in clinical supervision, because we do not want to produce a professional just go on practice psychomotor skill, but they also be able to evaluate self in themselves. What are deficiency, what are things they can improve on, so to promote a lifelong learning. So in order to do that, there often be some instructions or some modeling or some demonstration that supervisors have to give to supervisee, but also sometimes involve mutual problem solving in a clinical setting. So in all that, we often need, of course, some form of observation, evaluation, and debriefing and feedback. So this encompasses the whole process of clinical supervision. If you can notice, we have moved on to, our clinical reasoning to simulation. Now it's towards more on the hands-on. So a focus more on a job training supervision. You can imagine when it's talk about on-a-job training, is often talking about perhaps postgraduate or even final year student, more closing to ready to practice kind of situation. So that how we define clinical supervision is slightly different from academic supervision, which we can discuss that later in Q&A. So looking at a competency and professional competency, what exactly are we looking at? Of course, there are many things we're going to look at. Okay, they are generic, which is professionalism, communication skills, ethics, collaborative skills. These are really so-called soft skills a bit, right? And of course, discipline specific. Discipline specific, of course, every specialty, for example, ENT, surgery, medicine, we have a different way of defining what competent skills they are going to have. Similarly, as I'm a family physician, I will probably need to look at more what family physician supposed to be in discipline-specific skills, right? So you were talking about soft skill, and that can be something that is challenging in clinical supervision, right? So I'm just giving you an example of primary care competency. So these are the area of framework that we need to look up. Before we even talk about online, we need to go back to what exactly that we want to supervise about. So in this particular chart, it well summarize what a primary care doctor, or rather a family physician, should acquire. What are the clinical skills they should acquire? On top, you can see these are the clinical competencies in different ways. And of course, they are the generic skills like attitude, what attitude we should put up in front of as a family physician. How do we use science knowledge? How can we practice in context-specific area? So this is something that we need to go back before we start to have a competent clinical supervision, right? So of course, process of supervision, they are direct and indirect. So direct supervision, of course, on the clinical practice. So we often, what we do is on the job training. So during occasion of service, for example, in this particular example, operating in OT, a supervisor supervising a trainee, for example, certain procedures. So hand-on hand holding, something like that. So, but in our clinical practice as a family physician, of course, we will supervise in direct clinical consultation. So it mainly focuses on psychomotor skills. I'm not saying it doesn't involve affective as well as cognitive. Of course, it's all embedded. But the main thing about direct supervision in clinical practice is, of course, psychomotor skills. And on the other side is a debriefing and reflective practice, which I think Prof. Ismail Saidun has talked a little bit about debriefing and whatnot. This is the time where the supervision can be after clinical practice, or I put up here after clinical practice, but it can be before clinical practice, where we discuss cases. This is a lot of time emphasizing cognitive skill, for example, clinical reasoning, analytical skills. How can they self-evaluate the reasoning, and also affective domain? We can talk about, in different situations, how would the ethics be? What are the professionalism that we should portray? And what are values that they have demonstrated in their case-to-case practice? So we can be direct and indirect. So how can this then put into the whole picture? This is what I put up as borrowing from a constructive alignment, where we always talk about learning outcome, one, okay, assessment, and teaching learning. It has to come in a coherent manner. So in clinical supervision, I don't see a difference. So if you borrow the same model, assessment will be something like observation, evaluation, debriefing, and feedback. A very formative way of assessment, okay? And of course, teaching learning is instruction, modeling, demonstration, mutual problem solving. Mutual problem solving is where we solve clinical problems together with our supervisee to demonstrate how we solve things. Okay. Of course, how do we do that? Is direct and indirect. So the next half, maybe 10, 15 minutes, 10 minutes or so, I'm going to talk about how can this be brought online. Okay, we've been doing that all the time in direct contact with our supervisee. And this is the online clinical supervision that we can put out. So in direct supervision, they can, of course, prior consultation management, we can look at it. So it can alter patient's progress and treatment process. Okay, so we can have a pre-consultation round, for example. Okay, well, during consultation, we can have teleconferencing procedures like teleforecasting, supervisor looking at supervisee operating, for example. Okay, instructions through online methods, okay, teleconferencing. Rounds, okay, we have trolleys pushing, I don't have pictures here, but trolleys pushing around clinical rounds, and we have supervisor there, okay, a virtual supervisor there. Of course, this is really dreaming and thinking forward, but I think it's already going on. And when Sackett talking about evidence-based medicine, they are pushing trolley with rounds with computers and they search online directly. Okay, you think about the similar model, what evidence-based medicine database out there supervising how it can be, the knowledge can be transferred to clinical practice and clinical care. Of course, clinic teleconferencing. Okay, debriefing and reflective, this is indirect way. We can have virtual meetings. There are many platforms we can use. Okay, and written feedback, obviously. We can share clinical electronic medical record, for example. Many electronic medical records now online. If we are happening in the same organization, we can share clinical records. Distant learning, for example, not necessary. It can be within the same clinic. I'm in my clinic room, I'm my supervisor on the other clinic room. We can talk over the phone and we open up the same electronic medical record and we can talk about it. Okay, and of course, case-based discussion. I will show you some of that. Practice diary log that we have been using, and of course reflective journals, all can be written up to look at their ways of practice, their ways of thinking. Of course, when we talk about debriefing, reflective, indirect supervision, we talk a lot more about cognitive as well as the effective way of teaching. So we really need to zoom in. What are we supervising about? Then we select the right tools. How can we do it? Okay. And technology is here, obviously. So you can have a very low end or a technology less demanding. Email, for example. Okay. Text, even a Google Sheet. All right. So the supervisor can punch in their log, and then we can look at the log and whether they have done it well, they're not done it well. So this can be done in a very simple manner that things can be shared. Of course, synchronous meetings. That's the sharing of electronic medical record. It's now a lot of e-portfolio is coming in. So a lot of e-portfolio documenting what the supervisors are doing, and then supervisors can look at the portfolio page and see the progress of supervising. And this is a cartoon I just picked up, looking at the patient and a clinician and a supervisor on the laptop. So they're both sharing the consultation. So this is often possible. I mean, I'm not sure it's happening, but this is something must be there out there, but not in my clinical practice yet at the moment, right? So this is OT with a monitor. So I think because of camera and internet, good internet facilities, all these are all made possible, okay? So it's just how we can design it in a way, okay? So this is how matching of what we want in our outcome or desired professional skills that we want, and matching on the method that we are going to choose. So we'll see whether how it can be covered. Okay, of course, you will see teleconsultation with direct observation through some telecasting. How can we look at consultation skill, holistic care, and whatnot in clinical practice? Okay, but practice diary is very powerful in our experience to look at different ways of how clinicians or our supervisor able to appraise, for example, and make judgment in their clinical reasoning, for example. How can they rational judgment of prescribing and whatnot? Okay, so a whole range of skills that we want in our professional competency can be assessed through there. Okay, this is one of the practice log, or rather the practice diary that we have. We can actually just sharing emails, and we can have comments Later on, we can have synchronous teleconference. We have been discussing over Skype, things like that. So look at their practices, right? This is, of course, a video capture for telephone consultation. This is taken not for online or distance provision, but because material is captured on a video, of course, we can appraise the video. We can go through this video. The best thing about video looking at consultation is that we can pause the video and comment directly what exactly the question that is rightfully put up, not rightfully put up, and what is the next question, what is the inappropriate question in the consultation, and jeopardizing the rapport. All this can be stopped and replayed and taught through synchronous teaching. Right? So these are very powerful low end. I mean, that technology is there for many years. Right? And turning from the dynamics of supervision to online, that's something we really have to think about, as I spoke about just now. So this is a conventional way of supervision. We need to have a clear goal, needless to say, agreed communication style, relationship between supervisor and supervisee, and how online can affect this, right? So just go up a little bit. So online, of course, there are studies looking at how online or distance supervision compared to a conventional supervision. When clear to set goals, we often involve in supervisor and supervisor sit down together, discuss things. But online, can we do that? Of course, we can do that. But initial face-to-face meeting has been shown to, in a way, can increase mutual understanding, because online, not all non-verbal cues can be picked up. So because, just now I showed you a picture where people is drinking coffee while on synchronous session. Of course, many things that we do on the other side is not observable on the other side, okay? So we can't capture a lot of non-verbal cue, and hence the rapport and establishing our best way of relationship might not be that strong. Communication skill, obviously, okay, we have to fasten up the presentation. So two use have affect communication. Eye contact is different. I'm looking at you now at the camera, but I'm looking at my monitor now. Obviously, I don't have good eye contact. Sometimes I have a silent moment. How can that be perceived differently from the other side? All this has to be considered. Of course, the relationship, I've just spoken a little bit about rapport. So these are the things that we really need to create a mutual understanding. How can we use technology, right? And feedback obviously impacted on our clinical supervision. Written feedback, audio recording feedback, face-to-face feedback, all have created slightly differently, okay? So conventional way of technical aspect, for example, we always make ourselves present in real so-called conventional supervision. We sit down together with supervisee, we have logistic arrangement, with protected time, and we have close contact with our student while they're on practice. But online, that become a bit of challenging, all right? So we need to make ourselves present virtually. How can we make ourselves feel present, okay? So this is adapting to the technology. Of course, extra time for setting up platform. Be careful of multitasking, because now even I'm talking to you, I might be answering my WhatsApp, things like that. So this already happening, and we know it is happening. So when we do supervision with our supervisee, we need to take note of all this extracting adults on online, and confident level of supervising. So for example, in a real clinical practice, we thought we can supervise over, telecasting, but truly, are we confident our supervisee delivering the right quality of care to our patient? So therefore, online supervision in a clinical practice, I think it really have to call for a supervisee that is ready to practice a certain level of competence before we can have that to happen. And of course, document this is easier to document. Okay, this is a legal issue that is very important, because we are in a least distance supervision. Our practice, our opinions will impact on the outcome of the practice itself, the patient care. So, but for example, I'm in UKM and the other person in Klinik Kesihatan, for example, will my practice be called for a claim? Am I legitimate to practice in KK, for example? So all this have to be ironed out. Okay, because I hold responsibility to treatment to a Klinik Kesihatan, will that be allowed still, right? Of course, confidentiality, information transferred, we have to be careful on that as well. So doctor-patient interaction, with some patients expressing a sense of alienation. So if I'm in a clinical practice, supervising in Klinik Kesihatan, and my face appears on a laptop, you can see how patients can react to that, confidentiality issue. So how comfortable our patients is. It's a new way of supervision, if you like, in future. So not just us and supervising accustomed to online clinical supervision. I think the patient has to get used to the norm, a new norm as well. So the limitation, this is one of my last slide. We need to adjust for supervisees' competence level. We can expect different methods of supervision, and it requires supervisees' self-motivation, how to utilize online as well. So specific hands-on skill, of course, is not possible through online all the time. So this is just a supplement to our clinical supervision. Okay. My take-home message. Okay. So online supervision offer complementary roles, not replacing it, as what Professor Ismail talked about. So choose the right technology for its intended outcome. So often the outcome drives what can we do with online. So we have to be clear that for ourselves. So, and the last bit, of course, beware of human interactions with technology use. Supervisors, supervisees, as well as patient. So we are talking about professionalism that cannot be replaced by AI. Okay, something that we need to work on, right? So it's a complementary role. So with that, I end my sharing session, Prof. Zaliha.
Okay, thank you very much.
Hopefully I've done it in the shortest time possible.
Right, you finished in good time. Thank you. And it's question time now. I can see that quite a number of the questions have already been answered by the panelists through the Q&A platform. But I'm not so sure whether all the participants can actually see the answers to those questions. Can they?
I think they can, because yeah.
Right. Okay. If they can, I think we'll leave those questions out. There are a few more questions coming in. Okay. Ladies and gentlemen out there, if you have any questions, this is the time for you to post those questions in the Q&A platform. There's one question to Prof. Halina.
Yep.
On about DXR clinician.
Yeah, I think there's two questions that I can answer on that.
Right. Yeah. Maybe you can take questions. Yeah.
Yeah, there's one from anonymous attendees at 11:01. Basically asking for my opinion about virtual patients in DXR clinician, for instance, for non-linear judgment. Can we actually assess our student on that? So my take on this is this: the DXR clinician is very much designed for students who still think through the system too, which is analytical system, and they need to go like step by step. So that is the more or less to see how their competency at that level. But of course, when things get more complicated, particularly in therapeutic reasoning, I don't think the XR clinician would be the best to be an assessment tool. It will still be that face-to-face, and that is when I don't think any AI or robotic component is going to take over that. So as an examiner, you can always propose to the candidate certain circumstances, and they need to respond on that, and you can really see their non-linear judgment. So that's my take for that one. Another one is the XR clinician. Is it available for UKM student in the faculty? Yes, we actually have the facilities, and it is definitely under the care of the medical education department, and student can actually make arrangement to come over. And of course, they need to have their facilitators around. So we need to increase the competency and skills of the facilitators too, to assist the student. Otherwise, well, we are still in the beginning, and students actually express some kind of frustration, because they need to really go step by step, and I guess in the beginning it will be like that, but with the assistance of trained facilitators, we can overcome this. So I think that's the two questions for me, Prof.
Okay, thank you, Halina. There are two questions for Dr. Tong. One is about practice diary. Somebody wants to know more about practice diary. And the other one is from University of Brunei Darussalam. How do we move forward with remote learning with IPL?
Yeah, thank you. First of all, the practice diary is a practice of jotting down the cases seen. It's very similar to case-based discussion in its model, where we ask our participant or a supervisee to write down the cases they have seen on the day. So by right, a strict practice diary, they will write down almost all the cases in a sense. So they're not choosing the cases, so you can see the spectrum of cases they are seeing. And the format of how it's been written can be varied. You can write just the patient demographic, the reason for coming to the clinics, and their management plan. So then we can see whether their practice is according to whether guidelines or not, or deviation from the guidelines, and we will ask questions accordingly. The question we ask, of course, will be according to our domain, or why are we asking those questions. It can be evidence-based practice, practice prescribing, or their values in ethical issue in prescribing. So a lot of things can be asked with practice diary. So then we can reason out their cognitive thinking as well as critical use of many decision making. So that's in sum the practice diary. It can be used as an assessment tool in exam as well, and we have been using that as exam tools. Yeah. So that's quickly about practice diary, and of course the IPL. IPL is very interesting because IPL can range from the online platform for students to learn how to interact across profession, and towards the on-the-job training. On the job training, they will see real patients and how IPL is being practiced. I suppose here you're interested in looking at how online can be used and the remote learning. And for example, DXR is one of the two, for example. It depends on the platform you're going to use. So a case can be put up, and different profession will look at the case and then write down their plans. Or even the diagnosis or nursing care issues or pharmaceutical care issue for that matter, and they will need to share that and how to negotiate the plan. That is where interprofessional practice can come in. This agreement can be resolved online or not. That's one issue that we need to explore. But interprofessional, the gist is about how can we share our plan and know our role in each of our professional role in care of a patient. So if that can be put up asynchronously or synchronously, asynchronously, they can type in their answers and then they exchange through forum chats. So there are many platforms out there for us to learn. So yep, it's all, I think, possible to a certain extent, but face-to-face will be the last bit, last bit we bring them together. That's probably not online. Yeah. Okay. Your mic, Professor.
Yeah, thank you, Dr. Tong, for the answer that you've given. There is one question on simulation. I'll post this to Dr. Ismail. Is there a possibility to use virtual methods for postgraduate and undergraduate clinical examination?
Okay. All right. If you ask me, is there a possibility? I think there is a strong possibility that we can use this thing in the future. Maybe not now, but in the future. Why I say it's in the future? Because I think there are still not many MVR, medical VR applications or content available at this present moment. We in UKM also is actually trying to build up some of this MVR content. And I think once the MVR content is actually available, I think it will come in quite handy for us to use a virtual platform for assessment of students in the future.
Right. Thank you. Next question. This is on clinical supervision to Dr. Tong again. Do we need to change the clinical supervision technique if there is an element of assessment, for example, formative assessment?
Yeah, formative assessment, I think we understand formative assessment is really for improvement of practice. And there are many platforms, I've just talked about it just now. Definitely there's a change of format in formative assessment. So we need to know the limitation online I just spoke about. For example, some of the cues that we cannot pick up through online method. But the use is mainly for supplementary. I also read in the question about ensure sufficient. So that is a tricky bit. Ensure, how do we ensure that? So I think online will take us to a mile, all right? And then face-to-face will the next mile, right? So the format of the change, of course, you have to build on to, of course, practice diary is one of them, video assessment is one of them. A lot of time in MRCP, they use video as one of the assessment tools. So they record the real consultation, but confidentiality, legality, all these issues have to come in. So that can be a material for assessment, and format have to build flexibly in that way, I think, because it's really on-job clinical supervision. Yeah, it's not a learning, it's a learning, but it's on-job. It's slightly different from undergraduate teaching. Yeah. So yeah, I foresee the similar thing happening in undergrad teaching because I saw one of the questions as such. So you can videotape, you can ask students to write down the case and have a case-based discussion online. So that can be the bridge can be built that way. Yeah.
Okay. Thanks, Dr. Tong. I think I'll take one last question in the interest of time. There's 2 minutes left. This is open to anyone who would like to respond. Can you please let us know if interviewing students in a structured form and time limit can be used for clinical reasoning enhancement and open book with time limitation for assessment of higher order blooms? Anyone?
Okay. I'll take that part.
Okay, right, Halina.
Okay.
Up for the challenge.
Okay, the question is whether this online interview for in order to assess the students' clinical reasoning particularly, and that can be done. Basically, you can ask the student to see their own patients and they must prepare a summary, because that's another way of assessing clinical reasoning, particularly for those mature students in the final year. So they can actually have their own gallivanting time with the patients and have their summary ready, and they can actually present that to you through the Zoom, for instance. Yeah, and this is definitely we have to see them interviewing as well, but this is like doing it first. This is an independent self-directed learning, and then they actually present that summary to you. It is very rich in terms of opportunity to see whether the student is thinking, as a having the whole process. And in my own experience, you can really see whether they're still in the reporter stage, which is very irritating. They will report every single event, like going to Dr. A and being given a blue tablets, and still after a week went to Dr. B and given a yellow tablet. That is still reported. And you can actually give your input there and have them and slice them again, most probably in 2 weeks' time, and to see whether there's some difference or not. So I guess for the time being, particularly in this COVID MCO duration, you can do a lot of that. The setback is that our student might have seen the patient long ago and they might even have forgotten, but I actually did that in the first week of the MCO, whereby all my bedside teaching has to be converted into an online. And fortunately, they have all the summaries, because I actually asked for summary, never a long case presentation. And we had a very fruitful 1.5 hour where all the 6 students in the group can actually present their summary. And the feedback is good. They feel it is a more productive way as compared to in the teaching in the bedside, where we cannot usually have that. So I actually managed to use the same time, 1.5 hour of bedside teaching, but I assess all the 6 of them, which is unlikely in the usual bedside face-to-face, Rosa.
Right. Thanks, Dr. Halina. That brings us to the end of our session. It's 11:31 minutes now.
Prof.
Yeah.
Prof. Zah?
Yeah. Go on. So, you want to say something?
Yeah. Actually, I'm trying to answer one question, I think, which is interesting.
Okay.
Okay. How do we conduct our final clinical exam that's coming, which I think very relevant. Maybe if people can give the ideas on how this final clinical medical exams can be done to assess students' thing. Maybe I can start the ball rolling first to this thing. Okay. I don't have the answer, the correct answer, but this is again my opinion. Now, I think what we can do in the final medical exam, there are couple of components. There are components of history taking. There are components of communication, which is history taking. There are components of doing some examination or some elicitation of things. There are components of data interpretations, and basically some the way how you present yourself. So I think if you want to do the clinical exam, maybe it will not be the same as before. Concept was in terms of concept it's still the same, but in terms of how do we run it is going to be slightly different. We can assess in terms of by parts. In what I'm trying to say is actually it's like this. In terms of the history, the student can still take histories from the patient. They can do it in online in terms of the history taking. They can put a thing, we put in terms of time, they can communicate to this patient and take history, whatever which is important. And then come to where how they perform examinations. Okay, now examinations, we can do it if you want to see how the flow of examination, they will do it on basically screened SPs. Um, Basically SP who has been screened that they are not carriers or having this illness. And in terms of procedural that they need to do, with a few procedure when we normally in our clinical exam, we can ask them to do it on on a part-task trainer for this thing. And after that again we can have the Zoom thing for discussion, or even a discussion at a certain place. So these are the things that how we can break off or break up the examination component and still assess the exam and coming up with this thing. Example, like even like example in terms of data component, if they know where to put their stethoscopes, and we expect if that patient have a murmur, we can download a murmur from the internet, and basically when the student do their thing there and they said this is what you hear, so we want them to interpret that data of hearing a murmur or a craps or a wheeze or whatsoever. So I think this is again again my idea of how I think the clinical final exam can still be done.
Any other thoughts from the other two panelists?
Yeah, I agree with Prof. Ismail. I guess we always think physical examination meaning we have a patients there and demonstrating all the skill. But if we break down the assessment of clinical examination, there are many components of it, like placement or location is one. But one of the things also we will assess is if the case presented is such, what are the relevant clinical examination that you would want to do? There will be clinical thoughts of what next sign to look out for. So let the student think forward, and that part can be examined through not necessarily having a patient there. So we have to break down the clinical examination to different components and see which one can be tested online, which is a necessity really to have a patient there. That they will make the whole thing.
Yeah, just to add on, we have I have seen how this thing being done, and one of the university that I've seen this thing is TMU, Taiwan Medical University, where they break up the clinical long case, and they have student goes like into like an OSCE's punya arrangement, and it can be done for the 100 students. So it can be done. It has been done.
Okay. Fraza, I think there's questions about whether the slide can be shared. So I think I'm going to share the last screen where our email address are on that. So you can just pick and choose, and most likely write an email to us requesting that, and we will respond personally. So
right, thank you, Halina. And I think it will probably be shared on FB or something like that by the secretariat as well. I think Prof. Asmi is in the team. Right, so shall we end our session now?
yes.
Okay, yeah, I think it's past 11:30. So thank you everyone for a very enriching session. I'm sure many of our participants will agree with us. Thank you to the panelists. Thank you to the participants themselves for the stimulating questions. And we hope what has been shared today will serve to enrich our knowledge and skills as medical teachers.
Okay. Thank you to Bukhari and Shem
Yes,
for
thank you to the Secretariat as well, the Zoom team of the Faculty of Medicine, UKM. And I'm sure we'll all go back and, try to use as much of what we have learned today in order to enhance the teaching of our medical students. And with that, I would like to end this session. Thank you all.
Okay, thank
Thank
you.
you.
Assalamualaikum
Bye.
warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.